word. This refers to one of your early slides of sleep disordered breathing. What is catathrenia?
Oh, yeah, catathrenia. That is people who make strange utterances, or it sounds like words when they're sleeping. So it's just a bizarre form of snoring. Kind of, if you think about it, what it sounds like is someone's sleep talking, but snoring at the same time. So sometimes it comes across as moaning. Sometimes it comes across as broken up words, but it's really just another form of sleep disorder breathing.
Okay, thank you. Next question. Is there a treatment for a low AHI, let's say 4, but with a highly interrupted sleep, such as inspiratory flow limitation of 2000?
Yeah, so that's what upper airway resistance syndrome is. So an upper airway resistance syndrome, it's really like obstructive sleep apnea, but without an AHI greater than 5. So the reference standard for diagnosing it is with esophageal manometry. We put a pressure transducer down their nose into their esophagus, and we measure that change in pressure gradients across the upper airways. Well, I can tell you the only 2 places in the world that still do that are Walter Reed and Stanford, because patients don't tolerate it. It's kind of expensive to do. So a lot of times what people do is on in-lab studies, they look for evidence of flow limitation, so upper airway limitations. So they're not directly measuring that increased upper airway resistance that I was mentioning, but they can look for different patterns of flow limitation and then sleep fragmentation. So it's all the same criteria for sleep apnea, but without the apneas hypopias, and people will call that upper airway resistance syndrome. So if you think about it, it really is very similar to very mild sleep apnea. And if it's symptomatic, then the treatment is either positive airway pressure or oral appliances.
Thank you. Next question. Is there a specific treatment other than a sleep appliance to treat lack of REM sleep?
It's a tough one. So, if somebody has disrupted sleep architecture, so, what does it really mean? So we sleep in stages. So about half of our night is a more shallow sleep, N1 and N2. About, in a healthy person, about a quarter is, if just to make it simple, a quarter is slow wave sleep and a quarter is REM sleep. There's a night to night variability. As we get older, we start losing some slow wave sleep, but REM sleep stays pretty well preserved. There are a lot of things that can prevent you from getting REM sleep. One is sleep apnea. Because REM sleep is the most vulnerable state our upper airways are in. We have the most collapsibility of our upper airways. So if somebody has sleep apnea, they have sleep apnea and REM sleep. But sleep apnea or upper airway resistance isn't the only cause of a lack of REM sleep. Many medications, especially antidepressants, any wake promoting substance, caffeine, cigarettes, a lot of things can limit REM sleep. And so people can have a lack of REM sleep for a lot of different reasons. They can have a lack of REM sleep just purely because they slept in a sleep lab. And that's an unusual or strange sleep environment. So the question is there something we ought to do when someone isn't having a sufficient amount of REM sleep? Well, we know if they're having too much REM sleep and they're depressed, they're at a greater risk for a major depressive episode. If they don't have enough REM sleep, they're at risk for depression. They actually did a study of college students way back when, and they would come and sleep in a sleep lab, and every time they went into REM sleep, they'd poke them so they couldn't get into REM sleep, and they were measuring how it affected their academic performance. Now I'm trying to figure out what idiot would volunteer for this study in college that was purposely trying to ruin their academic performance, but they did it. And after 2 weeks, there was so much depression and suicidality that they had to stop the study. And rats, if you prevent them from getting REM sleep for only a couple of days, they'll actually die. So it is important for us to have REM sleep. And then the question is, what do we need to do something to treat it and people don't have it? And, well, not if it's not sleep disordered breathing. But what about just REM related sleep apnea? We'll think of that as the most mild form of sleep disordered breathing. There's a lot of people that are proponents for treating REM associated sleep apnea. So sleep apnea that only occurs in REM, but otherwise the AHI, the overall AHI is above 5. They've never shown that there was any long-term benefits to treating it. So at least I can tell you, If you're only having sleep apnea in REM, it's not normal, but it's probably not pathologic enough to warrant therapy. At least that's what the literature shows us.
Okay, thank you. Have you heard of a patient sleeping with closed mouth and snoring through nasal breathing?
Oh yeah. So I mean, snoring is, just like sleep apnea, there's multiple different places that we can obstruct. It can be, anywhere from nasopharyngeal, oropharyngeal, subglottic. And that's why things like, UPPs aren't universally effective, because people will obstruct in multiple different areas. And so really all snoring is just turbulent airflow. So you're going to hear that one way or the other, right? So if they're breathing through their nose, breathing through their mouth, it doesn't really make any difference. If they're having some collapsibility somewhere along that flow of air, you're going to hear it radiate. You can actually hear snoring through the neck in a person who's, otherwise their mouth is closed. So yeah, that's why when we put, acoustic monitors on people, we put it on their neck. It doesn't matter if it's coming through their mouth or nose.
The next question may border on a national security issue, and you may not want to be able to answer it, but as a former military officer myself, the question is, what fraction of the deployed U.S. troops sleep with an oral appliance?
Wow. I can't tell you a proportion, but it rapidly increased from the beginning of when after September 11th, and we started deploying more and more people, and at the time you could not go to war with a CPAP. Logistically, it was problematic. Where are you going to plug it in? A lot of specialties in the military. Some people deploy with electricity no matter what, right? Wherever they go, they're going to have electricity. But a lot of people deploy, in the front lines, and especially in an immature theater, when you first move in, there's nowhere to plug in your CPAP. So oral appliances were very important. And then, for as you can imagine, if you think your loud snoring annoys your bed partner, imagine what happens when you're sleeping with 40 of your best friends, and now you're in a tactical environment. And nobody likes to snore, right? They're keeping everybody awake, and they give your position away to the enemy. So a lot of people would be kind of forced to get. We had a lot of command-directed sleep evaluations early on in the war, and we try to crank out as many oral appliances as possible. So I would say, the beginning of the war, 2004 to 2006, we probably did over 1,000 oral appliances in 2 years. And that was, really, if you think about it, that was kind of early days of oral appliances. I mean, oral appliances have been around a long time, but I don't think they really gained popularity until after that. And, I used to talk to a lot of my other sleep medicine colleagues, and they thought I was crazy for doing so many oral appliances. And most of them had no experience with oral appliances whatsoever. And everything was pap, 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 pap. And, that's clearly not the way to go, right? I mean, it works fine for a lot of people, but it's not when you limit your choices to just one person. It's terrible. So I'm glad we had some early experiences with oral appliances. I will tell you, every time I've deployed, I make sure I give as many oral appliances away as possible, because I can't stand snorers. No offense to any snorers in here, but you keep me awake. And I love my sleep.
Plus, they protect you, doctor.
Exactly.
Okay. This relates to your program in terms of titration. How many visits does it take to titrate an oral appliance the way you discussed it earlier?
Yeah, if you do it well, too. I mean, it's more than that, obviously. But, we'll talk to people at the very beginning when we think they have sleep apnea. We'll start already laying down the tracks for here's your different treatment options. And then when they get diagnosed, we help them select what they think is right for them. If they choose oral appliances, they get a pretty comprehensive educational program up front. This exact same thing happens if they pick PAP, right? So we educate them on, everything they need to know about sleep apnea. A lot of fire and brimstone. It's like, if they don't treat their sleep apnea one way or the other, then they'll get fat, dumb, no one will like them, their penis will stop working. The same thing you want to tell all patients to scare them into, following what your guidance is. And then if they're going to get an oral appliance, we teach them the protocol. They'll get at least a mold made right then. And then the sleep dentist will see them several times just to fine tune, adjust that, make sure it's fitting properly. And then they start their home titration, and they come and see us after, a month or two, at least a month, up to 3 in some people. And then they'll see us if they're having problems advancing, or when they think that they've hit that sweet spot. And then that's when we'll do some form of home sleep testing. And then so they get, one at the beginning, one in the middle, and then at least one at the end of their when we think it's they're properly titrated. So it's really at a minimum of 3 visits, and then obviously more and more with certain patients.
Thank you.
But also we don't have just random or routine office visits. They come in when they get educated on what exactly, and then we send them home with literature or papers, and they'll come back when they think they're properly adjusted, or if there's a problem, so that we don't have them just routinely come back at 2 or 4 weeks or something like that.
Thank you. Next question. In determining optimal therapy objectively, why not prioritize RDI, given that this incorporates arousals / fragmentation that do not meet the criteria of an apneic or hypopneic event?
Yeah, so if you're doing a home sleep test, technically you're not actually measuring an apnea hypopnea index, you're measuring an RDI. So sometimes it's a little bit of semantics. So cessation of airflow with a resultant desaturation or arousal can only be measured on in-lab polysomnography. When we do, portable monitoring and home sleep apnea testing, we're really just looking at changes in airflow and their oxygen levels. So, technically sometimes it's a little semantics talking about AHI versus RDI. The RDI is going to have more variability in some patients than AHI. It doesn't, but in the end, I understand what the question, the person asking the question is asking. So it's really, are they well ablated? That's really what it comes down to. So if you're using home sleep tests, it doesn't really matter. It's kind of, they're synonymous with each other.
What would your next steps in management for the patient that is maximally titrated but has ongoing symptoms of an elevated AHI? Do you want me to read that again?
No, I got it. So,
okay.
So I guess the tough thing is so it's either an elevated AHI or they have persistent symptoms, right? So if you have advanced the oral appliance as much as you can, right? And they still have an AHI that's too high or persistent symptoms or sleep fragmentation. Well, now you got to ask yourself, technically they failed oral appliance therapy. But before you just jump and say oral appliance isn't the right choice for them, you got to look at what are the alternatives, right? And are there adjunctive therapies that you can do with that? So obviously, maintaining an ideal body weight and limiting alcohol, CNS depressants are all going to be very, helpful. But if they, sometimes forced positional therapy, just telling someone to sleep on their side is not positional therapy because you toss and turn at night. But, they have a lot of those devices that are designed to prevent someone from sleeping on their back. This is not new technology. Sears Roebuck catalog had it in the 1820 or 1850s or 1880s, snore balls. But there's a lot of different shirts and things that these devices you can put on that prevent people from sleeping on their back. You're trying to do anything you can to optimize the efficacy of oral appliance. The other thing I would tell you is elevating the headboard. So not more pillows. You don't want to bend your stomach, but you want to sleep on a ramp. I'll tell you this, everybody should sleep this way, whether you have sleep apnea or not. A couple of bricks, 2x4s, phone books, if they still make phone books, I don't think they do. But if you elevate the head of your bed 4 to 6 inches, you're not going to slide out the bottom of your bed, I promise you. But it just gets to your neck a little bit higher. That by itself will actually improve sleep continuity in most people, what studies have shown, and it will reduce the AHI. Now, will that push you over the threshold to be a successful therapy? Well, whether it does or not, you're going to improve their AHI somewhat. You're going to improve sleep continuity. It costs you nothing to elevate the head of their bed. So I would tell you to do that. So those are the other things that you can do. And then look to see if they have upper airway congestion. If they're chronic sinus congestion, then, a couple of months of nasal steroids can actually also improve the AHI. So I would tell you, before you just abandon oral appliances altogether, look at those different adjunctive treatments you can do, and then ask the patient, and everything's got to be in conjunction with the patient. Well, would they rather go to PAP? And if they tried it before, they hated it, it wasn't working, whatever the reasons, if their choices are the AHI that's not working as well as you want or no treatment, well, then obviously we'd all agree that the AHI, an oral appliance with an elevated AHI is better for that individual person. But I would tell you, for everybody, always strive for perfection as best you can. Look at those different adjuncts that are there, and maybe those can help somebody. But if oral appliances aren't providing an adequate therapy for that person, and that's got to be defined by each individual patient, then I would tell you they got to look for something else like PAP.
Okay, thank you. I'm trying really hard to not lose my train, but I think I got an electrical interference, and I got a question, a couple parts. I'm getting a thought that you may have already answered this, but let's try this again. If there is still snoring but no OSA as determined by an HST, what do? You may have covered that, but the patient's still snoring, but we've got rid of the OSA.
So remember that, all tests, even an in-lab polysomnography is not perfect, and it's going to miss some things. And HSTs are very good, but they're going to miss events as well, because we're really not measuring everything we measure in both a PSG or an HSAT is a surrogate marker. What we're really trying to find out is there increased upper airway resistance? And the only way to really determine that is with esophageal manometry, which, again, like I mentioned, nobody does anymore. So we're always looking for surrogate markers, right? We're measuring surrogate markers, and we're using that to determine whether or not someone has disease or whether or not that disease is well treated. And so if they still have snoring, but they're not having apneas and hypopneas, that doesn't necessarily mean that they're not having sleep fragmentation. And so if you've fixed the apneas and hypopneas and they have good continuous sleep and they don't have any symptoms, well, then I'll tell you the snoring is not that big of a deal unless it's causing psychosocial problems with the person's, bed partner. But I will tell you that it's rare. I'm not saying, let me rephrase that. It's probably fairly common that a person may have some degree of persistent snoring, but you're not measuring apneas and hypopneas. But it's probably uncommon that person doesn't still have persistent underlying sleep disorder breathing that's being missed by our limited ability to measure things with the current sleep studies that we do. So I would tell you, look and try to see if that person having normal sleep architecture, evidence of normal sleep architecture, good sleep continuity, sleeping through the night, having restorative sleep. And if they are, well, then, fantastic. Don't worry about the snoring. I think, like I said before, the presence or absence of snoring is the least of your concerns when we're trying to decide who has sleep apnea or whether that sleep apnea is well treated.
Okay. What are your thoughts on combination therapy, PAP and OAT? I think it's pretty cool. I will say the original device that came out, there was it was proprietary and it was getting pushed kind of hard without any data or science behind it. And I thought there was a little too much hype. We're scientists and we want to, okay, it sounds like it makes sense, but prove it. Don't just tell me it works, prove to me that it works. Now, other people have developed their own. There have been more studies. The studies aren't great. However, intuitively, it makes perfect sense, right? It's one of the problems with PAP therapy is
almost all the problems with PAP therapy and the intolerance of it is that mask interface. Putting a mask on someone's face and blasting air in their head. Amazingly, some people have a hard time with that. But it is effective, and oral appliances are great, and we all know that people on the call that do oral appliance therapy, there's a little bit of magic to it, right? So it's not how much you're advancing the mandible. It's not that you're only opening up the upper airways, it's that you're really stabilizing upper airways. You're stabilizing them, you're preventing that collapsibility. It's not how much you're pulling it forward or even how much you're preventing subluxation, but how much you're stabilizing the upper airways, which is the same thing we do with PAP, but we do with air pressure. We stent it open, it's like a pneumatic splint. So if you do, and we know that, oral appliances have their own limitations with their ability to create that upper airway stability. And we know that PAP has the limitations with that mask stuck on your face. And so if you put the two together, you're essentially using the oral appliance as your anchor, your harness for your mask, which is also going to prevent some subluxation. I think, intuitively it makes great sense. And I love the concept of it. The problem is that some of the things that came out originally were kind of clunky, and there hasn't been great data on it. But I think, if we have some that are kind of mass produced and not just made in somebody's garage, and we get good studies out there, I think we're going to start using them a lot more. I'm actually amazed they haven't taken off already because they've been around a while, and I love the idea of them. But I think what we're waiting for is, that something we can use on a large consumer basis that has evidence to support its use.
Thank you. What about the impact that chronic snoring has on possible development of carotid artery disease?
Yeah. So the question is, we know that sleep apnea triples your risk of stroke, doubles your risk of heart attack because it creates that sympathetic activation, increased catecholamine tone, repetitive hypoxia. All those things lead to increase in atherosclerosis and intimal thickening of our blood vessels. But why is there a 3-time increased risk of stroke and only a 2-time increased risk of heart attack, right? And it's because of the effect of snoring and the vibrational effect that actually just the vibration of snoring that leads to more intimal injury of our carotid arteries. So a lot of the studies early on that said, does snoring increase the risk of stroke? Those questions were, well, how many of those people really had sleep apnea that were just undiagnosed? And is it sleep apnea that's increasing the risk of stroke? But other studies more recently that have been a little stricter in defining, making sure people did not have sleep apnea still showed an increased risk. So snoring by itself is a risk factor for stroke because it's a risk factor for carotid atherosclerosis. So is the rest of the spectrum of sleep disorder breathing. But again, that the damage, the vibrational damage to the carotids is something that's very important, which is why I'm all for treatment of snoring. I'm not saying with PAP therapy, and I'm not even saying with an adjustable oral appliance, right? It could be an over-the-counter device that's that prefabricated something that just prevents that subluxation, cheap and easy. I think it's fine. It'll improve the sleep of your bed partner, and hopefully prevent you from getting divorced and having a stroke. So I'm all for it.
Thank you. Can you recommend a good home sleep study for office titration? What's your opinion of the PAT technology and the new Rings and Night Owl, etc.?
So the WatchPat, so some of these things that I told you that, when we look at measures, the traditional PSG and HSAT studies that are measuring changes in airflow, changes in thoracic and abdominal excursions. So are you trying? Remember, we're not looking for effort. I mean, we say we're looking for respiratory effort, but we're not. We're not measuring effort. We're measuring the results of effort. We're measuring, did they breathe? Did they take a breath? Did their chest rise and fall? Right? Is their diaphragm moving? And is that resulting in changing airflow in and out of the upper airways? And does it cause a desaturation event? And that's what's measured in lab studies. And so that's what most home sleep apnea tests are looking for. The watch pad and other things like that. Already we're already doing surrogate markers of everything. And now some of these studies are looking for changes in your arterial pulse pressure and waveform, and as a surrogate of a surrogate to determine whether or not you have sleep disordered breathing. The data showed that it was good. I was never a fan of it. I've never used those in our clinic because I just never, I was never smart enough to understand the technology. Really, I'll say that. I didn't buy it. I'm not saying it's wrong. It didn't make sense to me. Now recently, but now a lot of my colleagues felt differently. Just recently, the military has banned their use because there have been too many problems with over and underdiagnosis of some active duty service members. So that's something that just came out this week, or last week. Night Owl is the new, I don't say it's the newest kid on the block, it's the newest one I recall seeing. I think it's pretty good. The idea is, how do we mass produce things? How do we get more people studied? And I think things like Night Owl are going to be good for that, right? It's an inexpensive device that you can, mail to people, hand to people. It doesn't take a lot of technology to run this thing. And so part of me thinks, yeah, fantastic, get more people diagnosed, but where's the rate limiting step? So if you've got a bunch of clinicians and they can't get studies on people, well, then the rate limiting step is studies, right? And that was always the biggest problem. There were only so many sleep labs, and if you live in certain parts of the United States, there isn't a sleep lab for hundreds of miles. I'm sure it's even worse in Canada. You might be waiting 6 months to get a study, so that's no good. So then you have plenty of clinicians, but you don't have enough ways to study them. Well, if you increase the number of studies, fantastic, but at some point, are you going to have enough clinicians to take care of them? So just diagnosing someone with sleep apnea is completely worthless if you don't have a way to treat them, right? And if there aren't enough people that are practicing good dental sleep medicine and good clinical sleep medicine, well, who cares? Unless Walmart is going to start selling CPAPs, which I'm not disagreeing with, then why, and even if you're gonna do that, who cares if they have a diagnosis of sleep apnea or not? So, I think we have to be a little cautious with on the one hand, I want everyone with sleep apnea to be diagnosed, who has it, to be diagnosed, but we have to have enough clinicians and people in the health industry that can take care of them. So going back to the beginning of the question, we use a Knox T3 in our lab, but they're all very good. I think they're all great. They all have their pluses and minuses, and I would tell you, you got to look for the ones that have the lowest complication rate. So the ones that are crapping out or giving bad data, who cares? So they just do another night, right, with it on. But a lot of them will do 3 nights in a row just so you have one good night. I think ResMed makes a very good product. I think Knox makes a very good product. But it's really, to be honest with you, it's whatever one you can get that's cost effective. I think they're all good.
And this may be our last question, Chris. When do you declare the time to end oral appliance therapy?
When they're dead. So, the question is it's like, well, whether it's CPAP or oral appliances, it's not like you're going to outgrow sleep apnea, and that's a tough thing. And even if you lose enough weight, you resolve your sleep apnea, that doesn't necessarily mean it's completely resolved and won't come back. So some of the studies that we've done at Walter Reed looking at bariatric surgery, the people who continued their CPAP even after surgical weight loss, they kept the weight off. Those who abandoned CPAP, almost all of them regained the weight back on average 7.1 years later. So sleep apnea never goes away. It's always there, right? It's in the background. So we know sleep apnea is caused from being overweight, but sleep apnea by itself causes weight gain, right? From imbalance of leptin, ghrelin, and cortisol, and actually promotes weight gain. And so if you have untreated sleep apnea, you've lost a bunch of weight and you no longer have a normal AHI, doesn't mean you don't have any sleep disorder breathing. And if you don't continue treating it, you can just gain that weight back. Even people who've had successful surgical procedures, a large number of them will go on to redevelop sleep apnea down the road. So, it's hard to say that sleep apnea ever goes away. So when do you need to stop using oral appliances? I guess when you lose all your teeth. That'd be another one. So if you're dead or lose all your teeth, or you just want to give up on and start using CPAP. So that's really it. I think that we have to be cautious by letting people think that there's a way out. If you have high blood pressure, you're going to take medicines until maybe you change your lifestyle enough to not have high blood pressure anymore. But we know that's not realistic, right? No, nobody ever does that. We tell them to, but they never do. And so if you have coronary artery disease, you're going to be on therapy for life. And same, I think, with sleep apnea. If you got sleep apnea, you're most likely going to be on therapy for life. And so why give people, some thought that they can abandon therapy at some point in the future? Now, if they have complete resolution of normalization of AHI and resolution of symptoms, and you just want to watch them serially, that's fine. They don't have to continue. But at least I tell my patients, if they're getting on therapy, they're on it for life.
Okay. We're nearly at the end. I don't see any more written questions. If anyone is brave enough or wants to ask an oral one, just send me a note. Chris, as you and I talked in the preamble before the meeting, it's often what you learn after the lecture in the hallways and at the bars and wherever you gather with your friends. And as I was listening to you, I thought, oh, bricks under the bed, of course. Now in our country, we've suffered a huge loss of seniors in our long-term care homes with COVID. I'm sure you've experienced the same. And as I think about it, for years, hospital beds have been motorized, they elevate. Hospitals and long-term care. Have they been aware of this issue all along without being aware of it, sort of thing? Is that why hospital beds do that, or is that for ease of attending to them?
No. So, there's many studies, and it's actually standard for ICU patients that, we keep their head of bed elevated at 30 degrees. And that's a standard, right? In fact, if you don't do that, you get a ding with your quality metrics. But you got to be careful that it's not just bending people at the waist, right? So it's not bent. So if you bend at the waist, you increase abdominal pressure and actually can increase reflux. So it's really flat and elevated, right? So it's on a downward ramp, not with your head above your feet, not with your feet above your head. Honestly, like I said, everybody should sleep this way, especially people with heart failure, nocturnal reflux, and sleep apnea. But why? Like I said, there's no way it can hurt you, and it costs nothing. So, and definitely for your sleep apnics. And if you got them on oral appliance therapy or even PAP therapy, right? So we looked at it. We did a study, and just by elevating the headboard, the head of bed, it reduced PAP pressures by 1.4 centimeters of water. Well, that doesn't sound like a lot, but I tell you, there's a big difference between 8 and 10 or 10 and 12. It makes it a little more comfortable. There's a very big difference between 14 and 16. Once you get above 15, 16 centimeters of water, people are going to have a lot of mass leaks, and it's very intolerable. Same to imagine with an oral appliance. You're going to titrate them as much as you're going to titrate them. But if you drop their AHI, from 5 to 4 or 4 to 3, I mean, you think like it's a 25% improvement just by elevating the head of bed, right? And why not? 4 is definitely better than 5 when it comes to AHI, and 3 is better than 4.
Absolutely.
Every little bit helps.